Good evening, and thank you for joining us here on another program on blackdoctor.org. I, of course, am Ellis Dean, the Director of Programming at blackdoctor.org, and you are watching probably one of your favorite shows. You might not say it out loud, but it's probably one of your favorite shows here on blackdoctor.org, and that is House Call with Dr. Gigi, of course, with our favorite physician, Dr. Jihan El Bayumi, also known as Dr. Gigi. I call her Auntie Gigi, but that's between me and her. Y'all need to call her Dr. Gigi, all right? We got our own name. But in all seriousness, we have a wonderful guest that we're going to get to know just here in a moment and talk about surgery and bariatric surgery. And so I know there's some questions because obesity, unfortunately, is very, very rampant. It's a high level in our community, in the Black community. And so there comes a point where having surgery or bariatric surgery might be an option for you in order to lower and lose weight and then move on from there. Because as we talked on numerous programs before, there's over 230 conditions that are associated with obesity. And so we have to make sure that we got to get that weight down in order to, preserve our health. And so we're going to kind of talk about what that is, why, what's the best options for you when it comes to bariatric surgery. And we are in great hands, pun intended, with regards to Dr. Clark, because he is a surgeon. So before we get into anything else that we're going to talk to Dr. Clark, a couple of things I need for you to do. Number one, I need you to let us know where you're watching from. We'd like to know where people are watching us from all over the world. So please drop that in the comments and we'll give yourself and your city a shout out. Number two, if you know somebody that needs this information, somebody that might be contemplating bariatric surgery or just wanted to know some better ways that they can lose weight, tag that person or share this on your page so we can get this information out to them. And then finally, if you have any questions that you want to have asked and answered, please drop those in the comments as well, and we will get as many asked and answered as possible. Last thing I'm going to say is this. Anything that we say on this program is for informational purposes only. It's not to replace anything. If you are being seen by a physician, if you're under the care of a doctor, please follow your treatment plan. Do not alter any of your treatment plans based on any information that you hear tonight. This is just to spur that conversation when you have your next appointment, but not to replace what your doctor is saying. Did I get it all right, Dr. Gigi?
You did indeed, Mr. Ellis. Wow, that was great. That was a mouthful. You sounded like one of those people on TV that's advertising something and then at the very end it speeds up about everything. I see there's a Ms. Loretta from Pittsburgh. Welcome. That's great. And Miss Garrett from Phoenix. Wow, we got some people already logging in. Well, thank you.
Keep them coming. Keep them coming.
Keep them coming for sure. Thank you so much, Mr. Ellis, and welcome to Dr. Clark, Dr. Stephen Clark, who is from that wonderful medical school. He graduated from University of Michigan. Go Blue! Hopefully our team will continue to do well, even though they've won. I'm not sure. There are some weak plays there. I mean, we'll see. So he is a graduate of the University of Michigan Medical School. He also is a graduate of Harvard. And when somebody came up from Michigan, what I'd really like for you to do is to introduce yourself, but also with a focus on your career path, your educational path at the beginning, because, sadly, the number of African-American male physicians has actually gone down since you and I were in medical school, which is shocking. And so I want to talk about you first, and then we'll talk about your surgery and what kind of surgery you do. So please welcome Dr. Clark.
Well, thank you for the introduction. So I am, like most kids, had a lot of different interests, interested in sports, interested in school and academics, like science, like math. There were no physicians in my family, but medicine seemed to be a fit, with the skill set that I had and the things that I like to do. So, very fortunate where got accepted at Harvard, go to Harvard, finish my pre-med requirements in 2 years. And then I said, is this all there is? Number one. Number two, is this really what I want to do, as opposed to getting slotted in to be, matched by some algorithm? Okay, you're good in math, you're good in sciences, you should be a doctor. So I thought about that. My parents almost disowned me. I'm joking about that, but they were concerned, about what they perceived to be a sudden change of heart. And so I took some computer science courses and then actually worked for IBM for 2 years,
Mm.
and had a whole cohort of friends, including someone that Dr. Gigi knows very well, who went on to medical school, and I was working for IBM. And unfortunately, that was right when IBM was transitioning from the mainframes to PCs. And so at university, I'd taken some computer science courses and done some fairly high level programming, but IBM assumed that you knew nothing. And we were, those who are of a certain age may have seen punch cards, but that they were teaching us job control language punch cards. So I went to my boss and I said, I'm not saying I'm the guy, but I am telling you that I've done far beyond this. Is there any way, my training can be consolidated so we can kind of get out in the field? No, no, no. This is the way we have to do it. So after being bored for the first 9 months, for the most part, I said, I'm too young to be bored in a job. So let me think about things. And my friends in medical school all seemed happy. Of course, I only saw them when they were going to parties, but that's another story. And I thought about it, and there was something that I had said when I was sending out resumes for a job. I wanted my epitaph to be, "He helped people." So absolutely, as a physician, you can help people. So I said, cracked the Barron's version of studying for the MCATs. Took the MCATs, got a good enough score that I was a attractive candidate. Got in early to the University of Michigan, and ironically, at that point, my job became very interesting. And timing is everything. And so they thought I was going to business school, so they sent me up to Boston to talk to people. And once I told the guy I was going to medical school, he said, "Oh, good luck. There's no way I'm going to talk you out of going to medical school." So I went to medical school, and Dr. Gigi knows this very well. One of the things they tell you, if you want to be a surgeon, you have to like anatomy. Well, anatomy, gross anatomy, and emphasis on the gross, the cadavers are preserved with formalin. Formalin made me nauseated. And plus, formalin pervades every pore of your body. You go home, you shower, you're eating, you can smell formalin. I hated anatomy. I also parenthetically think anatomy should be surgical anatomy, because gross anatomy is only useful for people who are pursuing a medical academic career, not in academic medicine. But I'm going to be a professor. But that's a different story. So I thought there was no way I was going to be a surgeon. So during my surgical rotation, I went to the VA, and the first case. Well, actually, let me back up. My first rotation in medicine in third year was medicine. And that was interesting, problem solving. I like that. The second rotation was pulmonology. And the doctor did some bronchoscopies, and I got to see living anatomy. And all of a sudden, anatomy was very interesting and intriguing, and not, didn't go home smelling of formalin, didn't taste the formalin in my food. So I was like, So my rotation over the holidays was general surgery. There happened to be an African-American physician, Dr. Michael McLeod. I don't know if you remember him, Dr. Gigi.
Mm-hmm.
And the first case was a sigmoid colectomy. And they open the abdomen. I look in, and you see this living anatomy. And this person had a specific problem. They were able to fix the problem. They work with their hands. The patient got better, goes home, aloha. And as anyone knows, any career requires a lot of delayed gratification. In medicine, there's a lot of delayed gratification, but in surgery, you, for the most part, a patient has a specific problem, you help them fix it, and they go along their merry way. And that I found very, very gratifying, and I was hooked from that moment on. So I did my residency at the University of Cincinnati. Initially, I thought I wanted to do pediatric surgery, but for those of a certain age may remember, and student loans are very popular these days, student loan forgiveness. Well, they didn't have that in our day. They had something called guaranteed student loans. I had taken out loans as an undergrad, and I was very fortunate to get a residence tuition scholarship at Michigan, but I was running up against my GSL ceiling, which meant I would have to take out HEAL loans. At that time, they were 18%, and you had to pay the interest back when you were in school. So whatever amount you needed to borrow more to pay the interest.
No,
that didn't look to be very appealing to me. And some of my friends who had persuaded me to go to medical school because they were having fun at parties were in various programs like the health professions programs where they had to go to underserved areas. A few of them were in the military. And so I kind of thought about, no problem with underserved areas, but they don't want surgeons in underserved areas. What about the military? Well, Air Force bases, don't know about that. Army bases, some of them are nice places, but some of them are not. But the Navy, the worst thing that can happen to you at the Navy is that you're by a body of water. So I picked the Navy, and they gave me a 6-year deferment, which allowed me to do the 5 clinical years and 1 year of research. So during my residency, I thought about pediatric surgery. They want you to do 2 years of research. I thought about cardiovascular surgery. They wanted you to do 2 years of research. And the Navy said, no, you have 6 years. So general surgery it was. I did do a year of research, which is pretty much required by my program. Spent 4 years in the Navy, which was a great time. Got to see some interesting places, including beautiful downtown Mogadishu. This was, and Dubai, which was spectacular. Seychelles, Phuket, Perth, Australia, Hawaii, Hong Kong. So it was really a great experience. I need to back up. I'm a bariatric surgeon, so be careful what you either wish for or hate. So during residency, I did not like bariatric surgery at all.
What is that, by the way? What is bariatric?
Oh, yes, surgery? Thank you. I'm sorry. Bariatric surgery is weight loss surgery. And at the time, in the late 80s, early 90s, the procedures that were being done were primarily gastric stapling operations. Vertical banded gastroplasty was being done, or a silastic ring vertical banded gastroplasty. These procedures were better than medically supervised weight loss, but they were very complicated. The patients seemed to have a lot of complications. There was a lot of revisional surgery, and it just didn't appeal to me at all. So the other thing is, I know you can't tell by my beautiful good looks, but I'm older. We were doing everything open until my 3rd and 4th year of residency. We started doing things laparoscopically. At that time, people were doing weight loss surgery still with the open technique. So I was really intrigued by laparoscopy. Found it it made a huge difference in patients' outcomes and recovery. The first several times we did laparoscopic cholecystectomies, every time we would come see the patient in the hospital, back in those days, people stayed in the hospital after a laparoscopic cholecystectomy. I'd look down at their abdomen, I'd look at the small incision. I said, this is absolutely amazing. Instead of people being in a hospital 3 to 5 days, they'd be in a hospital overnight, go home the next day, and they'd be back to normal activity within a week. It was obvious. It was just obvious that this was a revolutionary change. And fortunately, I was at the forefront of doing that. So I incorporated
cholecystectomy is gallbladder surgery.
Gallbladder removal. I'm sorry.
So
gallbladder removal.
It's all right. So
yes. So we first started
opening up the abdomen. You use a small incision and a scope, and you pluck out the gallbladder.
Exactly.
There you
go.
Mm-hmm.
And so that was the first operation we were doing. Now the gynecologists, the physicians that take care of women, were doing laparoscopy, again looking at the pelvic organs, sometimes doing what is called a tubal ligation, where they ligate the fallopian tubes to prevent pregnancy. But the laparoscopy at that time was not as advanced when the gynecological surgeons were doing it at first. You had to look through an eyepiece to do the surgery, and it was very, very cumbersome. And we would do colonoscopies, where you look at the colon, or upper endoscopies, where you look at the esophagus, stomach, and duodenum through the eyepiece as well. Again, a nice technique, but very, very cumbersome. And then we got to video endoscopy. And that was another game changer. Instead of having to look through an eyepiece, the endoscope had a camera attached to it. It would transmit to a television monitor. So everyone could see what was going on, not just the person controlling the endoscope, but the anesthesia people, the nurses, of course, at a medical university, the medical students, the physicians, etc. And so the same thing with laparoscopy, and that changed the game. And so we started doing first taking out gallbladders, then we started taking out appendices. People said, "Hey, we can fix hernias this way." As the technology got better, want to back up, the original technology was a CRT, cathode ray tube, and the resolution was not that great. But then they got chips in the camera and the resolution improved. And of course, now we have high definition cameras and you could see better. And so we started doing more and more complex things. I remember in I think 1994, there was an article about the first laparoscopic bariatric surgery, which is weight loss surgery, which is the gastric bypass, which is, I hate to say it's the gold standard, but it's the longest lived procedure that we still do. And it took them 8 hours. And I said, they are out of their blankety blank mind to spend 8 hours doing it laparoscopically. Again, there's no way I would do that. Be careful about saying there's no way you're going to do something. So
you figured you can stop saying that by now, but you've said it.
Wait, is my wife around? She may offer a different opinion. So I was doing advanced laparoscopy, and I remember my wife, we were living in South Carolina. She hated it. So we don't live in South Carolina anymore. Imagine that. And when I came, people had asked me, "Do you want to do bariatric surgery?" I was like, "No." And when I came to Indianapolis, that's one of the first questions that they asked me. I was like, "I have no interest in doing bariatric surgery, none at all." But one of the manufacturing reps said, "Hey, have you ever considered doing bariatric surgery?" And I was like, "Is this a conspiracy?" I mean, it's like, what's that line? Do you hear the words coming out of my mouth? Right? It's like, I am not interested in doing bariatric surgery. He said, "Listen, I get what you're saying, but do me a favor. There's going to be a conference at Ohio State." I was like, "Man, you're just not scoring brownie points with me. You want me to go to Ohio State to look?" But that's a different story. He said, "Just go look. It's nothing like what it was when you were a resident and in your early years of your career." So, Columbus is 3 hours from, Indianapolis. It's an easy drive. I go meet the people. It's a nice little conference, and they show a live surgery. And it's like when I saw that removal of the sigmoid, I was like, "Holy smokes, this is totally different than anything we've ever done. I'm hooked." And that's how I got into weight loss surgery. So you would think I've learned to say I'm never going to do anything. I'm never going to do something, but I still say that. But that's how I got into robotics as well. So robotics is sort of the next evolution in the technology. But similar to what happened in laparoscopy, the initial robotic procedures were very cumbersome. The technology just wasn't ready for prime time. And so I tried to do some robotic weight loss surgery in the early tens. And that's why my hairline is receding. The procedures were very complicated, very cumbersome. The robot really wasn't ready for this type of complicated surgery. So they came up with another version of the robot and said, "Oh, this time it's different." It's like, yeah, right. But my partners started doing robotic hernia surgeries. And I said, "Steve, you really should look at this." I said, "Yeah, this is what they told me about this." He's like, No, this is different." So I had some complicated hernias that I needed to pass off to my partners, and I watched them do it. And I was like, "Oh, I can see the benefit of this." Then the guy said, "Yeah, you really should consider bariatric surgery on a robot." It's like, why? I've been doing bariatric surgery for this time for 18 years, very successful, low complication rate. At an age, is it really worth it to learn a new technique at this stage in my career? So once again, they drag me to a conference. I look up and it's like, eureka, this really makes sense. And so that's why I use robotics now. The technology has improved dramatically. The company that I use, I'm not going to advertise them. They have their own stapling device, which she didn't have before, which is integrated with their equipment. And the visualization is it's hard to describe how good it is. Laparoscopy gives you 3 times magnification. Robotic gives you 10 times magnification.
Wow.
Robotic gives you 3D visualization. You have the arms are robotic, so you have greater degrees of freedom and movement and articulation, and it's really spectacular. Plus, once you attach the robot to the patient, it doesn't matter what their size is. If they weigh 250 pounds, which would be someone with a BMI of around 40, BMI is body mass index, which is a weight by height measurement. BMI of 40 has traditionally been the cutoff for bariatric surgery, but you can have people with BMI 60, 70, someone who weighs like 350 pounds, 400 pounds, 450 pounds. Once you dock the robot, the surgery is the same with someone who weighs 450 pounds, 500 pounds, or someone who weighs 250 pounds. That was not the case laparoscopically. We would finish these cases, the difficult cases laparoscopically, and be physically exhausted. Even if the case takes a long time on the robot, I'm sitting down at a console using an interface, and I'm not fatigued. So it really has made a tremendous difference. And one of the surgeons I admire very much talked about how one of his former partners said it extended his career for 5 years. I love surgery. I love help. I truly love helping people. I love making a difference in people's lives and giving them a tool to help them improve their life. So
Wow.
that's what I do. I do also do general surgery, but it's my career was serendipitous. You know, I'm not going to sit here and say I had this. You know, everyone talks about plan everything out. Yeah,
Well, they say you make plans, God laughs, right?
Yes, exactly. I mean, if I did not do surgery at the Veterans Hospital with Dr. McLeod,
Mhm.
maybe I have an attending that doesn't take a personal interest in me, doesn't make it interesting. And plus, the residents also played a role. The residents were great. Maybe I have residents that were not so great, who are, Dr. Gigi knows there are some people who are very unpleasant in medicine, just like there are people unpleasant in any walk of life. So I was very fortunate. You know, you have to have a skill set, but you have to have opportunity.
Exactly. Well, thank you for sharing that. I have so many takeaways from your story. I don't even know where to start, but I want to, just like you gave homage to Dr. McLeod, I want to give homage to Dr. O.T. Randall. I
Oh
don't know if you
yes,
remember
yes,
Dr. O.T.
yes,
Randall.
yes,
So Dr.
yes.
Randall, who's kind of the godfather of high blood pressure, hypertension research, he and a whole bunch of other physicians, African American, it was actually predominantly African American male physicians throughout the country, said, we've got to bring up our numbers. So what they did is they all got on medical school admissions committee throughout the country. And actually, he was the one that interviewed me for medical school. You too? Wow,
Yes,
such a special
yes.
human being, and I had the opportunity to sit with him at an alumni dinner maybe a couple of years before he passed. So I mean, the reason I asked you about your career and your educational journey is because there are hopefully some young people watching this, and if they're not, we are gonna have the people watching share it with the younger people who may have an interest, and even if they don't, right? Because sometimes, thinking about going into medicine, especially being a surgeon, especially being an African American male surgeon, you just like, but everything comes down to those personal relationships. And we know when there are African American physicians caring for people of color, the outcomes are better. So this is not just, oh, somebody looks like me, how nice. No, it actually saves lives. So thank you so much for sharing that. Remember
All
Dr.
right.
Ralph Gibson?
No, I
Dr.
don't
Ralph
remember
Gibson
Dr.
was
Gibson.
at the dean's office, and he kind of watched over all of us. And he was
Hmm.
a pediatrician, very, very tall, kind of light-skinned man. So whenever you did well, he called you into the office. Whenever you didn't do so well, he'd call you into office. And he was just like your personal cheerleader, just a lovely human being too. So,
Yeah.
Ellis, I'm going to toss it to you and see if you've got any comments about the wonderful and illustrious educational career. Yes.
Can I just say one thing? Something that comes up all the time. People talk about the length of time it takes to become a physician. So it's going to take 4 years of medical school, at least 4 years of residency, perhaps 6 or 7. And so people say, wow, that's 10 years. That's my 20s. I don't know if I want to do that. But here's the deal. You're going to be 32 one day anyway. Do you want to be 32? Sorry, I'm on call, but I'll pass this off. I can pass this off to someone. So just give me a second. But let me finish this thought. Then I'll be right back.
Sure.
You're going to be 32 one day anyway. Do you want to be 32 doing what you want to do? Or do you want to be 32 saying, wow, I could now be what I wanted to be if I weren't so impatient? So don't worry about the amount of time it takes to become a physician.
I love that. I love that. But you're right. We do have to sacrifice. But then again, those parties were really a lot of fun. One thing about physicians that maybe the public doesn't know is we work very, very hard, but we do know how to party. We really do. There are some good times there. It was a lot of fun. And of course, during the 80s, there and before, there was some great music, right? Sorry to rag on the music of now, but I mean, our music was great. Mr. Ellis?
Yeah, I was, as he was, sharing the story, I hear, a lot of things. I love the point about the 32, right? Because I'm thinking about my own career and really, how long does it take to master whatever you're doing, right? The number of years it takes to get to that point where you're like, I got it. Here's, that is the time that you're spending in medical school and in your residency. And then even then at the end of that, you're still trying to figure it out and master it. So somebody that starts work at age 24, 25, 26, which is when I first got started in career, I didn't know what I was doing. I was just, and you were making do with just talent and potential, right? And so that was it. And then at some point in your career, probably around that 32, 33, 34 year mark, it's like, okay, potential has got to be realized at some point. And how are you going to realize your potential in a way? So you've had to have mastered it by going in, learning the ropes to skip and the ropes to know, all of those different things that you have to do throughout your life. And so I think it really is a testament to, one, maximizing your strengths and abilities and recognizing that at an early age. So I heard that when you're talking about, hey, you got bored. And what I heard was you got bored when you started working. You're like, wait, you got to Harvard, and you're like, is this it? Right? Almost like Kevin Durant did when he won the championship. He was like, is this it? Like, I thought it was going to be some better feeling about it, but you were able to pivot, and you had the ability to pivot. And the IBM, I remember that time. I was a child, but I remember that time.
Don't remind us, okay?
I do remember that time when they were switching.
I was fresh out the womb.
My kids give me grief now because I can remember a time when there wasn't a cell phone, right? Not even just no smartphone. There wasn't even a cell phone. If that person wasn't home, you didn't get them, right? And so that was it. And so you had to figure some things out. And so I think, so really, what I think what our audience particularly would like to know is, how do you make that decision? Is that something that the decision to have weight loss surgery, is that driven by the patient, or is that something that you do in concert with, this says, hey, this is something you might want to consider because the amount of time it might take for you to lose the weight could be more detrimental to your health while you're losing the weight, and we can go ahead and do the surgery to accelerate that, and then you start living a healthy lifestyle afterwards. So how does that process work?
So that's a great question. The vast majority of patients, I think, and again, listen, I've been doing this since 2002. In the 21 years that I've been doing it, I've only encountered one patient who hadn't tried multiple diets before they came for weight loss surgery. So there's this idea that it's a quick fix, and it is absolutely not. One of the primary care doctors used to say, with people that had bariatric surgery, they had successfully eaten through their bariatric surgery. So having the surgery you will lose weight initially, but you will not keep the weight off unless you kind of have a plan in place to manage your eating. And so something, people may remember, Dr. Gigi, I'm sure remembers the fen-phen craze
Mm-hmm.
in the 90s. Now, fen-phen was a very, very effective drug. And Pondamin was another member of that class, but it had some unfortunate side effects. But people were able to lose significant amounts of weight. But you couldn't stay on that drug indefinitely because of the phentermine, which was an amphetamine, a stimulant. So, but now we have new drugs, GLP-1 agonists, Wegovy, Ozempic are the two, and Rybelsus are kind of the three more prominent drugs. And you can get 20% total body weight loss. So if you weigh 250 pounds, you can lose 50 pounds with these drugs, and you can stay on these drugs for an extended period of time. It's not you don't have to, but you can. And so everyone tries medically supervised weight loss before they think about bariatric surgery, and that's after having tried to diet on their own. So it's a multi-year process before people come to see me. And people who come to see me are, except for someone, there is a disorder called pseudotumor cerebri. And what this is that people have elevated CSF pressure, and you can go blind from it.
Okay.
CSF is cerebral spinal fluid pressure, and if it compresses on the optic nerves, you can go blind. That is the only bariatric surgical emergency, because those people have to be expedited through the process, because once you lose your vision is gone. There's no recovering it. But everyone else, I would say, from the time they contemplate it to the time they have bariatric surgery is at least 3 to 5 years.
Okay.
Not 3 to 5 years in our program waiting to have surgery, 3 to 5 years trying various diets, exercise programs. A lot of people have had successful weight loss, but then the weight has crept back. Women go through, have children, problems with pregnancy, weight loss. Women go through menopause and the like. And then, so once you have made the decision that you're sick and tired of being sick and tired, I'm sure people have heard that phrase. Right. That's when they come to see us, and that's fine. Weight loss surgery isn't for everyone, and it's really, you hate to bring costs into the equation, but it's too expensive to offer to every single person who needs to lose weight.
Right.
So you can't. And you can lose weight by non-surgical means. There are people who've had success, not a large number, but there are people who have success, and we try to study those people and figure out how we can incorporate some of their strategies to make our bariatric patients more successful in their weight loss.
Yeah. I think one thing that doesn't get mentioned a lot, and I think physicians are not really aware of this either to the degree that we should be, are that certain medications cause weight gain. Mm-hmm. I know that I picked up a lot of weight during my 2 chemos for 2 different cancers because I had to be on very high dose steroids. Mm-hmm. And once you gain that weight, boy, that is very tough to get rid of. And I'm still struggling with that. But I think so. Medications certainly can cause weight gain. Depression can cause weight gain. Either you eat too much or too little. You sleep too much or too little. Some people, when they get depressed, lose their appetites. Others don't, right? So there are other conditions that can sort of cause weight gain. And I think it's important that when we are looking at somebody considering having bariatric surgery, they should really go and see a clinician, a generalist, to make, whether that's internal medicine or family medicine, whether it's a physician or a nurse practitioner, physician's assistant, to really make sure that there's nothing else going on. And then, to your point, Dr. Clark, there are people who will eat through their surgery, meaning that they will eat after the surgery has been successful in the weight loss and gain the weight back. And that really speaks to some other disorders, such as binge eating. Mm-hmm. So binge eating is a disorder where really you have to treat that with cognitive behavioral therapy, and in some cases medication, because to your point, if we don't address the underlying cause, you'll be back at square one after having this big surgery. So that I just wanted to sort of put my 2 cents worth in. But are there
No,
some
that's
patients that you say no, you're not going to have it because you think that they may be
sure.
psychologically not ready?
Sure. That's a great point, and I failed to mention it. We do have, and I've insisted on it throughout my entire bariatric career, that patients see a psychologist to get screened. Again, it's not losing the weight, it's keeping the weight off. And there are categories of DSM classifications where we will not do surgery. We're very concerned about borderline patients.
Oh, yeah.
I have done a schizophrenic, which I thought would be a hard exclusion, but it's not. But the binge eating disorder it's a monster. And the other thing that happens, you talk about emotional eating. Our brain, chemicals affect our brain. Food, despite even even organic food, it's chemicals, and they can affect your brain. And it's not just the trope that people eat chocolate or ice cream or peanut butter or whatever when they're stressed, or food that your nana used to cook or your mom used to cook. But the thing about binge eating disorder and other addictive personality disorders, often when you take away their ability to use food, it gets transferred somewhere else. So they become shopaholics, or they become gamblers, or some people have become promiscuous as a transfer of that addictive component of their personality.
Yeah. Yeah, which is, I think, an important thing. So, of course, now there are these medications that you brought up. And I can tell you, as a general internist, this has become the bane of my existence because everybody wants it. Everybody does. First of all, insurance companies have gotten wise. They are now refusing everything unless you have diabetes. And the cost of these medicines, I think if you pay out of pocket, it's $1,000 a month. But I don't think that there's enough discussion about some of the side effects of these medicines. Now, medications, I actually tried them just to try to see, with just the smallest dose, I felt so nauseated, really nauseated. I couldn't. But other ones that are coming up, because these are new medications, right? They haven't been around for decades and decades, but people now are having long-term side effects. Not everybody, but some group, we don't know how many yet, because it's not been around for a long time, where their intestine actually slows down significantly and they develop chronic constipation. It's not something that you could just take a pill for. I mean, bad, bad. We also know, and this is again not really discussed, the thyroid cancer risk. So there are people who have in their family certain kinds of cancers in which these medications can really, bring them out. So how is somebody, I'm sure you're getting a lot of this, how do you decide between medications and bariatric surgery? For you, what is it that makes you decide, oh, this patient may be a good candidate for surgery versus, hey, look, try these other medications?
I am one that kind of lets the patient steer the discussion. But I do want to add a lot of the reason that these medications work is they almost give you what's called gastroparesis, which means your stomach doesn't empty at the normal rate. So that's why you're full. Excuse me, just a second.
Mhm. So gastroparesis, just to expand on Dr. Clark. You good?
Just give me a second. I'm
Okay,
sorry.
I'll just have you put yourself on mute.
I got him.
Good. Got it. So gastroparesis is something in which, when you eat food and it goes down your esophagus and into your stomach and then makes its way, the waste products go out through the colon, there's a certain rhythm of that. And as you get older, people who are older know that things get slower. everything gets slower. And that's why you hear of sort of geriatric elderly people always complaining about bowel movements because things have slowed down. But there's also other conditions such as diabetes, which affects the nervous system, in which they can develop gastroparesis. And that's awful because people with diabetes can get into this loop where they're vomiting, their sugar, gets out of whack. And
Right.
actually, the elevated glucose can make the gastroparesis worse. But now, Mr. Ellis, we're seeing another group. I'm taking care of a few people, and they do not like to hear what the cause is, but it's weed.
Mm.
Marijuana can cause this cyclical vomiting cycle. So, and then of course, people use the marijuana to help with the nausea, or I'm like, no, 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 that is what's causing your problem. So, just like with everything, we're always looking for that magic bullet, me included. Look at I'm a patient, I'm a human being too. I'm not just a doctor, right?
Right.
So I get it, especially when it comes to weight. You gain weight, and this is a very judgmental society.
Yeah.
And yes, there's been fat acceptance, but as we saw, even Lizzo was giving people a hard time for their weight, right? But studies have shown that physicians are the worst in terms of traumatizing patients because of their weight. You'll
Yes.
hear studies where a woman will go in to get her glasses, her eye exam, and then the doctor will be lecturing her on her weight. I mean, really,
Yeah.
she's coming in to get her eyes examined. So these are the realities, and I think it's true, especially for women, that we in society get judged a lot. So people then look for really sometimes very desperately. So you're a psychologist, Mr. Ellis. I mean, help enlighten us on these subjects, because I'm from the standpoint of not just addiction, but self-esteem.
Yeah, one of the things when Dr. Clark was talking about it, I started thinking about um, punishment, right? And people can punish themselves, and there's multiple ways to do that. Overeating could be one of them, right? And so there is a lower self-esteem, uh, and there is this feeling of not being good enough as part of that. And so instead of some people take that feeling and overachieve, they do everything and they want to prove to everybody that they are good enough. And then the other side of that coin is there's those people that pull back and just really let their appearance go, and they do that, and they overeat as a result, and they let themselves go in that direction to show outwardly how they're feeling internally. And so it really is a tricky place. And some of those personality disorders, like when you talk about borderline, that is one of the most significant ones, and it's the hardest to treat. All personality disorders are hardest to treat, but there's probably there's a few others. I was also thinking about like body dysmorphic disorder, and that's diagnosable. That could be a reason for someone to seek out these quick fixes, right?
Right.
I think there's
Certainly in the plastic surgery world.
Yes,
And
Michael Jackson was
right.
thought to have
Yeah.
suffer with the body
But
dysmorphia.
I also want to talk about another category, especially amongst women, and that is women who've survived sexual assaults and sexual trauma.
Yes, they don't
Right?
want to be attracted.
Yes.
They don't
So
want to be
Dr.
attracted
Clark is
anymore.
agreeing. I've certainly seen it. And if you think about it, when you've been assaulted as a child or as a young adult or any time, but especially as a child, what happens is that your weight becomes like a way of protecting you,
Mhm.
right? But there's also another aspect of it, which is the self-soothing of eating. It's comforting.
Yes.
Are you back with us, Dr. Clark? Great. Okay. You're shaking your head. Yes. And you please tell us about the patients that you see.
Now, the sexual abuse and PTSD percentages are sky high in bariatric patients.
Mm.
And what Dr. Gigi and Alice were saying about um, eating and soothing, and it's very, very real. And I mean, who among us has not reach for comfort food at some point in their life. And if you
Everybody
have,
finds to count.
yeah, and if you have enough stress, if you've suffered sexual abuse or some other trauma,
Yeah.
you see it a lot. You see it a lot. We have a lot of damaged people in our society.
Mhm.
And unfortunately, mental health care is stigmatized and not readily available. And so people are self-medicating. And yes, I'm calling food a medication.
Oh yeah, it's absolutely.
So how do you then decide, who you said you sort of the patient can help to make that decision.
Sure.
You
Sure.
have them go through a psychological analysis to make sure that their expectations are realistic and that there's some of these other issues such as the sexual abuse or the body dysmorphic disorder are sort of identified up front. So then you have the surgery. How long does the surgery take?
The two procedures that I do are the sleeve gastrectomy, where you take out about 70% of the stomach. We use a calibration tube, which is about a half an inch wide, and we cut a pattern kind of around the calibration tube. That's the sleeve gastrectomy. Sorry. I'm a popular guy tonight.
Yeah, always.
Not always, but tonight.
Well, when you're doing a show on BDO, that's when it usually happens.
Like, oh,
yes, it is. That's it is. Hey, I didn't realize it was going to be so quick with the increase in popularity. But for me, for patients choosing a procedure or choosing to do medically supervised weight loss, it's their choice. I present the second procedure we do primarily is the gastric bypass, Roux-en-Y gastric bypass. We create a pouch about the size of your thumb, which is your new stomach. You bypass the majority of your native stomach, and then you bring a loop of small intestine up to connect to the pouch so the food gets rerouted. So we give the patient videos to look at, where they see pictures, short videos of the procedures, and we have all the surgeons in our weight loss center talking about various types of procedure. And I tell the patient, it has to fit your eye. If the idea of me taking 70% of your stomach out and it's an irreversible procedure doesn't go well with you, then you should not have that procedure. On the other hand, if I tell you I'm going to be rerouting your intestine and you freak out, you shouldn't have that procedure. Now, there are some people who shouldn't have a particular procedure because of underlying medical conditions. So as an example, the sleeve gastrectomy is the most popular procedure done. But the sleeve gastrectomy itself can cause acid reflux. So if you have acid reflux to begin with, and sometimes people have acid reflux and they will have what's called a hiatal hernia. That means that where the esophagus comes through the diaphragm to join the stomach, that opening is wider and a portion of the stomach can come up. And because of that, people are more prone to developing reflux. If you have that, we can fix your hernia and do a sleeve, but understand the sleeve itself can cause reflux. And how do we treat people who have severe reflux after a sleeve? We convert them to a gastric bypass or a Roux-en-Y. If you have problems with how your esophagus works, what we call esophageal dysmotility, then the last thing you want to do is create a sleeve gastrectomy, which is a high pressure system, because that esophagus is not going to be able to overcome those higher pressures. We're going to have to convert you to a gastric bypass. On the other hand, if you have extensive abdominal surgery for whatever reason and there's scarring, we may not be able to physically do a gastric bypass because there are too many scarring, what we call adhesions. Or perhaps you have really bad arthritis and you need to be on a non-steroidal drug. Well, we don't want you to take non-steroidal drugs if you have a gastric bypass because it increases the risk of you getting an ulcer in your pouch. then you shouldn't have a gastric bypass. There are a couple other procedures, duodenal switch. Now people are doing a SADI and then something called a one-anastomotic gastric bypass, which are not as popular. But all procedures have their downsides. But the most important thing is that the procedure makes sense to you and you're intellectually ready to deal with the consequences. I've seen people who 6 weeks to 3 months after surgery, it's like, I want this reversed. And it's like, well, we can reverse the gastric bypass, but I won't reverse it for at least a year unless you have a medical indication. Just so it makes the reversal a little bit easier, and then also buys time, and perhaps you're just grieving for the loss of your comfort food. And once you get over that, you'll be fine. In fact, one of the surgeons who trained me from that other university in Ohio, no, I'm kidding, from Ohio State, he had a patient, and I'll try to be as vague as possible, who 3 months after surgery wanted it reversed. It was the gastric bypass, wanted it reversed. He was very unhappy. Doc, you got to reverse me. You got to reverse me. You got to reverse me. And this particular person was grieving over the loss of food. And the doctor said, listen, I will reverse you, but after a year. And at some point it clicked that he did not have to eat the same quantities of food he was eating to enjoy his social life. He could go out with his cohort, do the exact same things, just eat smaller quantities of food. Mm-hmm. And once he came to that realization, he didn't want his bypass reversed, and he went along his merry way. So it's, we say surgery is a contact sport, and I'd say bariatric surgery is a contact sport on steroids. There's a lot going on. It is absolutely not easy. And Dr. Gigi in her practice, and I'm sure you too in your practice, Alice, you have some patients, they take to what you recommend and they do great. And you're like, man. Then you have other patients who, like, did I operate on you? Did I make a medical recommendation for you? Did I make a therapeutic recommendation for you? And I don't know why. I've seen some patients, I was like, oh gosh, there's no way they're going to do well, and they do great. I've seen other patients like, oh man, they're going to do everything, and you look at them a year later and they've lost 10% of their total body weight. And it's just like, what happened?
So what is your goal? As a surgeon, when
Sure.
somebody comes in, what's the average amount of weight that people, percent-wise of their body weight, do they lose?
Okay. So we aim for 30% total body weight loss. We used to do percent excess weight loss, which is a calculation based on BMI, which is, yeah, we would use the same number for men and women.
That's a whole nother show.
Makes sense. Yeah, whole nother show about BMI. Yes, Michael Jordan is obese according to BMI.
Yeah, no kidding.
So which shows you how ridiculous that is. Actually, LeBron James is a better example for the contemporary example of the fallacies of BMI. So we want people to lose 30% of their total body weight. So if you weigh 300 pounds, why don't you lose at least 90 pounds, 250, 75, 400, 120. So it's, because if you weigh 600 pounds and you lose 70 pounds, that's very different than if you weigh 210 pounds and you lose 70 pounds.
Right.
So we lose percent total body weight. 10% of our patients will never hit that number. And then 15 to 20% will regain weight back late. Now, the 10% who don't hit that number, there are some people who are just non-compliant. But there are also people who don't respond metabolically to the procedure, and that's the real head scratcher. The people who aren't binge eating, the people who keep the accurate food diaries, and that's heartbreaking because they put their life at risk. They've done what they're supposed to do, and they don't get the outcome that they want. Yeah. I'd say probably that's about 1% to 2% of the initial failures are people who just don't respond metabolically. And I'm glad that number, I wish the number were lower, but I'm glad it's that low, because if 10% of the people fail despite their best efforts, that would be difficult. I need a.
Sure, no problem. So, just to begin to summarize, because we only have a few more minutes, um, we should be doing everything in our power to get our young people, African American, but especially African American boys and then young men, interested in the sciences so that they can grow up to be wonderful surgeons, such as Dr. Clark. We need them desperately for all the reasons that we know, but particularly from my vantage point, health equity. Two, delayed gratification is part of the career of medicine, but I think it's worth it. And whatever you choose to do, something in service, I think is worth it. When it comes to bariatric surgery or any other surgery for that matter, it's important that you go to a surgeon that doesn't always operate.
Right.
So can you talk about that, Dr. Clark?
Right. My kind of mantra is if you don't want the surgery, I don't want to do it more than you don't want me to do it. Um, and then there are people who are just bad candidates.
Yeah.
Our department chairman used to say they could have surgery or an anesthetic, but not both.
Mm,
And then the last one are people who are just not prepared. Like I had a patient who want to fog up the details, so not to reveal an
mhm,
identity,
mhm,
who had had a problem for years.
mhm,
Um, had a BMI over 50, so means they were at least 150, 170 pounds overweight.
mhm.
But wanted surgery like yesterday. And when I explained, how our program worked and there were steps to go through, it's like, I'm not happy with that. I didn't say this, but I was thinking, it's like, you didn't become overweight a week ago,
That's true.
Mhm.
Yeah.
and so there are steps that you have to take. We want you to meet with the dietitian. You have to see the psychologist. You have to show that you understand what we expect of you and the things that you need to change going forward. You have to be seen by the medical doctors. You have to do preoperative testing. It's not, we know that if I just put up a sign and said, we'll do bariatric surgery for food, people would line up around the corner.
Right.
But are they going to have good results? I haven't done you any favors if I've done a bariatric surgery on you and a year later, well, 2 years later, you look the same today as you did before I did surgery, and you had, a 9-month honeymoon where you were in great shape and doing everything, but then you're back where you are. And now what are your options now? More bariatric surgery, more of the same.
Mhm,
So I
mhm.
think, we've learned a lot in bariatric surgery and almost every reputable program has a medically supervised weight loss component, a psychologist to evaluate you, and an extensive screening process to make sure that it's an appropriate fit. It's a great operation, but even great operations can cause disasters in people who are not ready.
Well, believe it or not, our time is up. This hour went very, very
How
quickly.
can that be? This must be a
It-
time, must be a
yeah, so I'll give I'll have
time
you.
travel.
We had we had a time bypass. We bypassed.
Yes. Hey, you. So I'm just going to say a few words and toss it to you, Dr. Clark, and then have Mr. Ellis close us out. But I wanted to say thank you because it makes me so proud to see you and to see you talk and to see your success, and go blue.
Yeah, can I sing "Hail to the Victors" or will
Yes,
that
yes, yes,
cause?
yes. Any parting
Cause
words from you, Dr. Clark?
um, when I was going through my existential angst as between my sophomore and junior year, one of my dear friends sent me fragment of Langston Hughes' Dreams. Hold fast to dreams, for if dreams die, life is a broken winged bird that cannot fly.
Mm,
And I would encourage you to think big. Um, I put on my pants one leg at a time, just like you do. There are people who are far smarter than I am who have flamed out in medicine. There are people who I am smarter than who are much more successful in medicine than I am. You know, if you are interested, seek out your chapter of the National Medical Association. Almost all of the physicians want to help and mentor you. I participated in a Black Men in White Coats.
Yep.
And I gave out 50 business cards. Please call the office. I'm happy to have your child shadow me, et cetera, et cetera, et cetera. No calls. My son has sent, who's in medical school, sent some of his friends. I told them, hey, anybody else, I'm happy to share my knowledge. Somebody help me, each one teach one. Mm-hmm. So please reach out. We are willing to help. We have great advice to give you. We can help you navigate the landscape and give you a better opportunity of getting into medical school or allied health, physician assistants for people who say, well, I hear what you're saying about 2232, but still, is there a shorter path I can take? Yep. And you can become a physician assistant, which is a burgeoning field.
Mm-hmm. Well, let me just say that Dr. O.T. Randall is smiling down at you because you're continuing. No, I'm serious. You're continuing his teachings. Yeah.
Yeah, I think
the funny thing about Dr. Randall, he asked me, it's like, why do you want to come to Michigan? I was like, oh, it's a great school. He says, but the weather sucks 8 months out of the year.
Fortunately, I grew up in Michigan, so that wasn't an issue for me.
Yeah. Well, I grew up on Long Island. The weather's not great there either. So if I were from Southern California, I might have said,
But yeah, I would say I agree with you. I think that we need to identify potential students earlier. We need to get them as early as grade school. Fourth grade is that same time where that prisoner pipeline tends to happen. We have to start building our own pipeline, identifying those Black students, those students of color that are showing an aptitude in science and math, and then build their village at that point, right? And then help them get through there, because everybody's had a village. I've talked to a number of doctors over my career, and they all have talked about their village that helped them get through. And so if we can get kids early and wrap our arms around them, we can get them later on. The other thing I would say for people is be mindful. I know that mindfulness is a concept that is out there in the lexicon, and people don't really understand it, but it's really about being intentional, being self-aware, and being intentional about what you're doing every day. And it's not about the quick fixes. It's not about hey, I'm going to, in 24 hours, 48 hours, my life is going to be completely changed. It's about focusing on what you can do today. And if you can do what you need to do today, tomorrow will be better. And then focus on tomorrow when tomorrow comes. So it's about being in the moment, recognizing where you are, and the awareness that says, here's what I'm good at, here's what I'm not good at. Sharpen the strengths, work on the weaknesses, and then we can get better each and every day. The final thing I would say is that since we're talking about bariatric surgery, make sure it's the right decision for you and that you are working in concert with your physician or your surgeon. I love what Dr. Clark is saying. He's making you go through these steps. It's not going to be a quick fix. It's not going to get you all the way to the end. Work in concert with them, but make sure you have a plan pre and post surgery. Have a plan on both sides of that equation. Otherwise, you might be disappointed with the results. And that's not what anybody's goal is. So again, I want to say thank you to Dr. Clark for your time. You see how busy he is. He get called. They're like, hey, you in that Black Doctor show? You need to come on. So make sure share this with a friend. Like and share the show. Please like the show. Click that little like button. I see some people have already done it. Thank you so much. Again, thank you all for joining us. And we'll see you next time on House Call with Dr. Gigi.
Thank you. Thank you. Thank you.